process as well. So having said that, I think we can start off with the case, and thanks for all the sponsorships. That's been growing quite a bit too. So wonderful that you're getting all the support to continue to grow the program. So with that, Dr. Kasturi, if you want to get started.
Yes, sir. I'm just sharing the screen. Is the screen visible, sir?
Absolutely.
Okay. Good evening, good morning from wherever we are. I'm Dr. Soumya. I'm a pediatric cardiologist. I'm currently working in Padmavati Children's Heart Center because we are a new institute. I just wanted to show a little bit of where we are from. So Dr. Balaji and other Indians, whoever are there, can definitely relate to the most powerful and most financially capable god in India. That's Dr. Balaji, and he sits on the top of the 7 hills in Tirumala, and we are a part of his institute, which means that they have a trust, and our hospital is being run by that. So this is our small hospital for now. We are just in the first year of inception. We have just renovated a old space, and we have tried to find our niche. And then in a year and a half, we are going to for our own institute. It's called Padmavati Children's Heart Center. In the last 11 months, 1 month short of a year, we have successfully completed some 800 surgeries, of which 500 were this open heart surgeries and 300 were cath interventions. We don't charge any of the patients. Everything is done free of cost, both from the trust and from the government. So these are all the pictures of the children who got benefited from this. We even do newborn surgeries, and we do adult cardiac interventions also. So this is about where we are from. And now to the case. So today I'm presenting a 15 months old male child who is asymptomatic. The mother doesn't give any history at all. He's a firstborn child. He is incidentally detected to have a low heart rate at 9 months of age. That is when we saw the child first. There was no positive maternal, natal, or postnatal history. There was no history of any abortions in the mother or anything. No history of sudden cardiac death or similar complaint in the family. There was no history of any fever with recent fever with joint pains or travel or accidental ingestion or anything, and he is appropriately immunized for age. The weight and height, according to Indian norms, it's acceptable. He is not failing to thrive or anything. He is very playful and active child. He responds, he communicates with normal development. There was no dysmorphism. The heart rate was 70 per minute, which is normal, regular, normal volume. There was no delay. Saturations were 98%. Without any obvious auscultation findings, except for the low heart rate. We have done a screening echo. It showed a structurally normal heart. There was no chamber dilatation. Biventricular systolic and diastolic function was normal. There was no pulmonary hypertension. There was no communication either at the atrial level or the ventricular level. This is the ECG of the child, which we are done at 9 months of age. Do you want me to read the ECG, sir?
So what sorry to butt in, Anjan, I forgot to tell you. What I thought was if the audience could look at the ECG for a couple of minutes, and then there is a question slide that follows. So there's a quiz about the ECG.
Thank you, Balaji. I knew you were on top of it. So if the audience can look at the EKG, give it about 30 seconds to see what they see. And I guess there's a question slide that follows, and then we can have the experts chime in. So this is at 9 months of age, and the patient is presenting at 15 months of age at this point. So can we go to the question slide?
Sure, sir.
All right, if people can put in their responses and submit it. And in about okay, we can look at the responses. And okay, interesting. 40% said sinus rhythm, 50% said second degree heart block with 2-to-1 conduction, and 10% said complete heart block. So if we can go back to that EKG, and maybe Tony or Beth, either one of you can take on, and if you want to address that EKG and explain it to the audience what you see.
Shall I go, Tony?
Sounds good. Yep.
Okay, excellent. I'll just thank the presenter for a great case. This ECG is a little bit tricky. I do think that it represents 2-to-1 AV block, but the P wave is often hidden in the T wave, so you have to look for some clues to see if it's there. It's most obvious in lead 3, so if you look in lead 3, you can see quite clearly that there is a mostly upright peaked P wave that comes through. And if once you found that timing, if you look at the other T waves, what you'll see is that in almost all of them, in the upstroke of the T wave, there's a little bit of notching, a little bit of a more high frequency activity. And that's really the clue to look for. The P wave is always a bit sharper and more jagged than the T wave. So if you see that kind of jagged irregularity in a T wave, that should always be a hint that there might be a P wave there. So I'll draw your attention up to V1, which has an inverted T wave, reasonable for age. And if you look at the downstroke, the Q, so to speak, of the T wave, you can see that there's a bit of notching, and I think that's actually the P wave hidden in there. The next thing that I would do would be to take calipers to this, because what you're wondering is if this a perfectly regular sinus rhythm with 2-to-1 block. Is this possibly blocked atrial bigeminy, which we would expect then that the blocked P wave was slightly early. And it looks to me like, eyeballing without calipers, like that blocked P wave might be coming just a smidge early. So this could be a blocked atrial bigeminy, although in lead 3, the P waves look awfully uniform. So you could also just have a ventriculophasic sinus rhythm, which means that the rate of your sinus is adjusting just slightly to match up with the ventricle, but I don't think we have enough to prove it here. That's my 2 cents.
Great. Tony, did you have anything else you wanted to add?
Yeah, I agree with everything Beth said. I think, you know, one important thing about this ECG is just, again, ECGs are not interpreted in a void. So if, you know, this was a 25-year-old man, I might not scrutinize it quite as much. I'd look at it and say, oh, it looks like sinus, you know, but knowing that this is too slow for the kid, you know, it sort of raises our level of suspicion. And you'll find that, you know, many EPs, when we interpret ECGs, we find P waves where maybe other people wouldn't. But in this case, you want your level of suspicion for extra P waves to be high. And I agree with everything Beth said about the peak T waves. And then I think one bit of advice that was taught to me, I think it's from the Boston lineage, is care enough to measure. So if you think they might be P waves or maybe not, then get out your calipers and see if they caliper on through and see if they're regular.
Wonderful. Now, 40% of the audience actually picked complete heart block. The fact that the PR interval remains pretty steady, would you say that that's in the differential, or how high or low would you put that in the differential?
You know, I would, I guess I probably put the wrong thing. I think I would put, I don't know on this. I think just because the P wave and the QRS time out, and we would have to measure them all, it doesn't necessarily mean that they're conducting. So this could easily be complete heart block as well.
I think I would say that, yeah, multiple ECGs are always very helpful. What the calipers, again, we love calipers. I would pull out my calipers and see if I could prove that there was a difference in the rate from the beginning to the end of the ECG, which I think there might be. I mean, there might be a little bit of kind of underlying variability. If your R to R interval tracked perfectly with any changes in your P to P interval, that would be a way to rule out complete heart block. But the rate's steady enough here, I don't think you could do it without calipers. But if you could prove that at the very beginning, your P to P, and you could just worry about the visible piece at this point. Don't struggle on the ones that are hiding in the T wave. If your interval for P to P was exactly the same as your R to R at the beginning, and then at the end you saw a slight shift, your heart rate slowed just a tiny bit or sped up just a tiny bit, and your R to R followed that, you could probably prove whether or not you had heart block. If your P's to P's didn't change at all through it, you'd need another ECG to try to find a different rate and reestablish that.
Wonderful. Thank you, guys. All right, we can keep going with the case.
Okay, sir. So we also thought it was a 2:1 AV block. And yeah, this we have done. So p-values.
All right, so the question is, what should be the next evaluation? Echo, Holter, maternal testing, genetic testing, or MRI of the heart? All right, the response is in, and majority, about 68% picked Holter or other monitoring, 23% echo, and 10% picked maternal testing for autoantibodies. We can have maybe Tony, you want to take this on? And
yeah, I think that's what I would do next. I think it's first of all, it's the easiest test. It also helps us prove, do more of those measurements and sample, have a larger sample size. And it also allows us to see if there's slower rates or there are periods of higher grade block or things that are more concerning.
I agree with that completely. I think the snapshot of a single ECG gives us a lot of information, but the Holter really will give us much more of the tendency over time. There'd be hopefully periods on there where we could definitively prove to ourselves the highest degree of block that we're seeing and see what kind of average heart rates and that kind of thing. So completely agree.
Just a quick question. Would you let this child leave your clinic without an echo?
And I was going to ask that, Susan. That's a great point. I think, the question was worded, what would be the first step? But in reality, what you end up doing in clinical practice and the patients in your practice, would you end up getting an echo anyways? And even the maternal antibodies at that same point, if you're worried about it. So I think that's a great point. Experts, what do you think?
Yeah, I agree. I mean, I think we would do an echo on this patient too. So I agree.
We're very lucky that in practice, we rarely actually have to pick just one test. So it was the right question. It was the right answer for the question, but I think most of us would get that. And I believe Dr. Katsuri had actually provided a normal echo as well. So we had that little preview.
Yes, and we also have to be mindful that, there's an international audience, so sometimes echoes may not be as readily available as they are over here. And if you had one test, that would be the Holter, but if you had other tests available, you would probably pursue those as well.
So there's a question in the chat. Can maternal antibodies cause presentation so late? I also had that question. What do the experts feel?
There definitely can be some correlation. Some women with autoimmune disease, their children will not have complete heart block, or they'll have wonderful junctional escape so that they don't present clinically until they start to slow down. I think the further you are from the gestational period, the less correlation you might have, because the maternal antibodies can also wax and wane a bit. So at this age, I think it's probably a less critical measurement, maybe a little bit less helpful, because if it's negative, I think that doesn't mean that there wasn't a potential exposure in utero. But that would be my thought process. I think we get it a lot of times, but I do think it's a little bit more academic and interest's sake. It's not going to change how we manage this child.
All right, we can keep going, Dr. Kasturi.
Yeah. We also did a few more little investigations than this. We sent a thyroid profile, which turned out to be normal. We sent a serum electrolytes, that also was normal. In our setting, more of an infectious, other than the Lyme carditis, diphtheric carditis was very common but the child didn't have any history of anything. We just went back and checked his throat and all again, but everything was negative. So we also ended up doing a Holter monitor. But we didn't do it when the child presented at 9 months. This is the ECG when he presented again at 15 months of age.
So, Dr. Kasturi, maybe if you've said that, I apologize, I missed out. You told me he was asymptomatic, but at 9 months, why was the EKG done?
Yes, sir. He was completely asymptomatic. He just came to the clinic because somebody had picked up a low heart rate.
Okay, so it was done for the low heart rate. Okay, good.
This is the ECG again at 15 months. In this, prior to what we had seen, the PR interval had slightly prolonged from what it was at 9 months of age. Still, there was this 2:1 conduction of the AV block. Sometimes there is this P which is marching between. This P was not conducted. All this was new. This P not conducting was never seen before. It was always a 2:1 block with a normal PR interval. This time, after 3 months, like 6 months, there are few non-conducted Ps, and wherever even the P was conducted, there was a prolongation in PR interval, and few Ps were not conducted.
Well, let's see if our experts, what they feel, what they want to add to this. Beth, do you want to take this one on?
Sure. So I think, clearly now we've got second degree heart block, and specifically we've got Mobitz 2. So when we think about risk of progression and risk of pauses and all of that, we like to differentiate between Mobitz 1 or Wenckebach and Mobitz 2. And here you've got this episode of 3-to-1 block that happens about 3/4 of the way across the page. So that sort of pushes you out of the Mobitz 1 interpretation, and you have quite variable, because the next 2 beats actually go through 1-to-1. So you don't have complete heart block. You can see those QRSs getting pulled forward. The second to last and third to last beats on the rhythm strip are clearly pulled forward. So it's not complete heart block. That's always a nice thing to see. And then also the third QRS on the page is also pulled forward. So I think this is really nice, clear evidence of a second degree heart block.
And while, Beth, you're looking at this Holter, what other things would you be concerned about on the Holter, or the questions you'd be asking on the Holter monitor?
Absolutely. So average heart rate is critical. We know that that's one of the things that can help us determine whether or not a pacemaker might be needed. And then also for, what your longest R to R interval is. Are you getting sudden long pauses? And in second degree heart block, that's actually often more of an issue, where they'll go nicely along with 2-to-1 or first degree block, as we see on the first part of the strip, and then suddenly multiple P waves get dropped. So we really look for sort of those sudden long pauses, because that's one of the other things that might indicate the need for a pacemaker.
And is there a certain number or a cutoff that you say, okay, absolutely, this is it defines the needs a pacemaker, or you take, a spectrum of things? How would you kind of take the RR interval and the average heart rate? How do you put that into the clinical picture?
Tony, do you want to take that one?
Sure. Yes. The most recent guidelines would actually don't really specify either of those things. I guess in congenital heart disease they may, but it most often now we go on symptoms. So that's what guidelines would say in terms of placing a pacemaker. That being said, older guidelines used to use like 3-second pauses or other numbers like that. But they're not in the current guidelines. So I think most of us have some mental threshold of, if you see like a 10-second pause, you're much more likely to put a pacing system in, but there's no absolute number. I think still symptoms guide most of these decisions. That being said, symptoms are often not defined in the guidelines. And so, they can be anything from growth restriction in kids, obviously fainting and things like that are obvious symptoms, but sometimes people are less active than they otherwise would be, or they just choose things that cause them not to have symptoms. And so sometimes it's really hard to figure out what are symptoms in kids with bradycardia.
For sure. And I would add to that symptoms can be quite atypical. For example, nightmares can be a symptom for kids who are having pronounced pauses at night. Some of them will present with nightmares. So that's a little pearl to think about if you have a kid like this who's having frequent nightmares. May not be related, but we've definitely seen a couple of kids. And I would say, Antonin, answer to the sort of other part of your question in terms of average heart rate, that's become a little bit more unified in the new guidelines, and it's pretty much 50 for the vast majority of the population. So that one is stuck around.
Yeah, and I think.
Sorry, there's a question in the chat. Somebody mentioned Dr. Jyoti Prakash. ECG seems like complete AV block. So can you go over again, one of you, why this is not complete AV block, please?
Yeah, for sure. So if we start on the rhythm strip on the bottom, lead 2, the first thing that you see is 2 beats with a PR that's prolonged but pretty steady. Again, calipers, we would want to really measure that and see if it's actually exact. But the next beat you see, so what is the third QRS on the rhythm strip, is actually pulled forward. So it's coming at a much earlier rate. So that right there definitively proves that you don't have complete heart block. If we count the P waves, 1, 2, 3, 4, it's the 4th P wave that clearly conducts and pulls forward. And again, then you have a blocked P wave, you have a long PR conduction, and again, the next one, so we're probably 6 or 7 now, pulls forward the QRS. So seeing that pulling forward of QRS where you have shorter R to R intervals, that's your evidence that it's not complete heart block.
Yeah, I think the irregularity in the RR interval actually tells you that there is conduction. I think the question was, if it's irregularity, doesn't it tell you it's complete heart block? No, it's the other way around. The irregularity actually tells you that there is conduction from time to time. And one other point I wanted to, just stress what you mentioned, Beth, and that is the average heart rate, because oftentimes the heart rates will dip below 50, and people panic when they say, well, on the guidelines, heart rate below 50, and don't we need a pacemaker? And I think the key word here is average. Average over what time? I don't think that's defined, but could be over a day, could be over days, but it's the average heart rate and not a one-time.
The other term that's come up in the chat is the word grouped beating. So this is a word that sometimes gets used. Can you clarify that word, please, one of you?
Sure, I'll take this one. Yeah, you can see this on the CCG, but maybe group beating would be 3 or 4 beats in a row and then a pause, or 2 beats in a row and then a pause. And so you certainly see that with the times of 3 to 2 block on this. And so instead of a regular QRS, it's what Dr. Batra was talking about, the irregularity and sort of groups of beats with a pause.
Very nice, guys. Should we continue?
I also have a question, sir.
Oh, okay.
No, there is this change in QRS morphology in few of the beats. Does that suggest anything, sir? Does it say that the bundle of his or the location of the block or anything like that? The
In my
conductive
mind, yeah, I see what you're talking about. I think that it's subtle enough that in my mind it could just be a very subtle aberration, because you're seeing it always when you have a pretty big long short kind of a pattern. So if you were seeing that at steady R to R intervals, if the QRS is marching along and very regular, and you saw those kinds of changes, then I would be suspicious of conduction system disease further down. When you see it only on beats coming after with a long short pattern, and it's so very subtle as it is here, I probably wouldn't assume that it means anything bad.
Okay. No, we thought that this is a new thing which we had seen, some P's which are not conducted and a change in the QRS morphology. So we thought that this child might progress to a complete heart block.
Yes, for sure. I would be worried about that regardless. Even if we decide the QRS change isn't big enough to tell us, this going from the 2-to-1 to now having 3-to-1, and I would definitely this would be a kiddo that even if they don't meet indications now based on their Holter, I would certainly be continuing to follow, because I would anticipate this would progress, hopefully very, very slowly, so they can get big first. But I agree, that's definitely something to watch.
And Dr. Kasturi, there's a couple of, okay, so the Holter one
Yes.
is also over the average heart rates. And Dr. Balaji actually posed a question as well. What would we ask the parents to watch for? So
Yeah, I think change in energy, decrease in energy, sometimes manifest as feeding or growth abnormalities too over time. And then obviously the big ones would be syncope, or things that I think parents would already be looking for.
great. Because you can go the Holter monitor. Just tell us the average heart rates, the low, the high.
Average heart rate for 24 hours is 68 beats per minute. There were some episodes where he had supraventricular tachycardia, sort of a thing with bigeminy. There were episodes where his sinus beat itself had increased and the conduction rate has increased, so that he had a normal sinus rhythm. And there were even episodes of complete heart block. That might be just in deep sleep. I'll show the runs on it. So the average heart rate was 68.
Okay. And how about the pauses? What were the longest pauses? I see 2.5 seconds. No, there was none actually.
No, sir, 1.46 seconds.
1.4.
In the excess of 2.5, there was nothing. But the longest RR pause was 1.4.
All right. Does this help us in any way, experts, if you want to comment?
So I would say that this is pretty reassuring. So you have an average heart rate of 68, with the knowing that our cutoff is 50, where we start to get more concerned. Your longest pause is only 1.4 seconds. So I think very unlikely to be associated with symptoms. That's very reassuring. The other thing that's nice to see here in terms of overall bradycardia and symptomatology is that the child is actually able to generate a pretty nice max heart rate. It seems like conduction improves, likely with exercise. The kid was doing something fun at 8:50 in the morning that morning, or late for school, running for the bus, but something was happening. And I guess not old enough for that. And we're still 15 months, but really nice max heart rate, which is always nice to see that the children can generate that. The PR shortened, you have 1-to-1 conduction. So from a likelihood of developing symptoms, I'm always happy to see that they can generate a max heart rate if they need it. one of the things we can see in some of these kids with this kind of variable heart block is that if they get sick, the febrile illness or something like that, and they're unable to increase their heart rate, that can be a time where they become more symptomatic and more vulnerable. So I always like to see them able to respond physiologically with a better heart rate.
So there are a couple of questions that came up on the chat. First one is from Peter. We've been focused on we've been focused on AV conduction, but is there any concern about the persistent LVH on these EKGs?
I would say in knowing the echo really helps. And so I think the fact that there isn't LVH on the echo is reassuring with that.
There's often some left ventricular enlargement, right, in patients with significant bradycardia. In order to compensate for it, they have to increase their stroke volume. We've actually seen many patients with this phenomenon present as a heart murmur, because they have a flow murmur because of the increased cardiac output. So that may be what it is. The question that I had was about, even on the previous slide where we saw that what would be considered quote unquote high grade AV block, here we are seeing that sometimes the child's able to go 1-to-1. If this was a purely AV node problem, when the atrial rate increases, if anything, you often see more blocked beats, right? Because the AV node is not able to keep up with that rate. Whereas here, you see the opposite phenomenon, that the AV node conduction actually improves. So I think we are seeing two things. There is an intrinsic AV node problem, but then there is also an autonomic issue. Depending on the autonomic modulation, the AV conduction actually improves in this child. So some of that so-called high-grade AV block may have been, I'm just throwing it out as an idea. Could that have been just the baby being a little vagal?
Yeah. And I am assuming what you're pointing out, Balaji, is something that's reassuring and actually a good thing for the patient, right? So good things mean way away from the patient.
Correct.
And another question that was on the chat, if any of you want to take on, is do you see short QT on that EKGs anywhere?
I think they looked pretty normal. They always get a little distorted on this type of presentation where we've really played with the sweep speed. But I think on the EKG, without having actually measured it, I didn't get the impression of a short QT.
I'm just going to throw out something. When I see a baby like this, I'm actually more afraid than when I see a baby with congenital complete heart block. Because like you're looking at as bad as it can get, but here we're not looking at as bad as it can get yet. And we don't know how the baby's going to tolerate this.
For sure, you have to watch these kids. Absolutely.
And part of the reason why you said that, Susan, is because it's progressive, right? Not because what it is, but because it's getting worse. Is that?
Absolutely. Yeah. Whereas with complete heart block, how much worse could it get?
Correct. So this could be progressing. We don't know the etiology completely. And
well, I'm going to be a devil's advocate to Susan. It can get worse because if you have complete heart block and your heart block is infrahisian or below the AV node, and you start having, say, broad QRS escape rhythms and slower escape rhythms, it can get worse even in complete heart block. We can't take the escape junctional rhythm for granted. So one of the things I always look closely at the Holter monitor is whether I want to make sure that all the QRS complexes on Holter monitoring are narrow, and I'm not having runs of broader QRS complex.
Absolutely. Great point.
Yes, exactly. So I think what I'm hearing from both of you is no matter what, you're going to watch these kids closely. You're going to probably do, frequent Holter monitors. How frequent? I don't know. I mean, in this particular kid, the experts can comment what they would consider an appropriate timing for how often would you follow or do Holter monitors or anything else that you would do?
Yeah, I think, I mean, at least every 6 months, probably even if as first getting to know the patient sooner than that, maybe every 3 months or so. So whatever I'd have access to, I'd probably want to do several Holters in the first several months.
Yeah, I agree completely. Little more frequently in the beginning as you get to know them and get some idea of both the, you know, the range of their responses and also what kind of trend you're on in terms of worsening conduction. You've already seen some worsening from the 9-month to the 15-month mark, and we really just don't know the slope of that progression. So I tend to do every 3 months for the, you know, for at least a couple of intervals, and then we'll stretch out to every 6 months if I'm not seeing dramatic changes between the 3-month interval.
Absolutely. And is it fair to say that even though that was one of the choices in the question, that at this point you would get SSA and SSP on the mom, even though it may not impact what the outcome or what you manage, how your management plan, but would you do that, order that?
I think I would if the mom were symptomatic and so it had implications for her care, or if there was the possibility of future pregnancies, because there'd be implication for those. If there are not going to be any more children and the mom is asymptomatic, you know, depending on how easy, how expensive, I certainly wouldn't make the family pay for that unless I thought that there was going to be benefit to the kid or to the mom who might have undiagnosed disease that would be important to know about.
Dr. Kasturi, do you know if this was done?
Sir, we didn't pursue the mom to get the SSA and SSB. With the brief history, we knew that there were no history of abortions and all, but we told her that this might, you know, come in the next pregnancy. So we told her to get it done, but you know, we didn't get the reports yet back.
Well, like Dr. Stevenson said, you don't have to, but it's just an option. So that's great. It's good to see that, you know, there's a spectrum. Should we move on?
There's just a couple of Holter things. This shows that there is a supraventricular tachycardia with bigeminy for some time. This is the complete heart block.
Before you go, you want to go back to that? So
Yeah.
I know you have supraventricular tachycardia. I'd like the experts to comment on that. Do they agree with the reading of supraventricular tachycardia on that Holter reading?
I think so again, you see this group beating, right? Like we saw before. And you do see P waves. I don't know if we can totally march them on through, but I think we probably can. You see some P waves and T waves and other things. I think most likely this would be sinus tachycardia with block, with second degree block, either type 1 or type 2, depending, you know, on P waves. So, and this might bring up a good point. Sometimes the Holter systems have, the more abnormal that the Holter is, the harder time that the computer algorithms have in interpreting them. And that's actually probably the harder time that we have in interpreting them too.
Yeah. So this looks like 3-to-1, right? The sinus tachycardia, like you mentioned, and every third beat is maybe not getting conducted.
Yeah, so I would typically describe this as 3-to-2, and that there are three QRSs or 3 P waves for every 2 QRSs with only 1 dropped beat. That's how I would typically describe it. I think that if you start just to march people through a little bit, if you start with the first P wave that you can see, and let's concentrate on the middle lead, so it's a little easier to follow. So you've got a P with a slightly long PR and a QRS. Then in the upstroke of your T wave there, you've got another P wave. Can you see that that little notch there in the upstroke of the T? I don't know, Dr. Katsura, if you can point. Yeah, exactly, right there. Excellent. So that one blocks. And then you have another P wave that's quite visible. So that is a 2-to-1 right there. But starting with the P wave where Dr. Katsuri is, excellent. So we have a prolonged PR, but conducted. We have a P in the upstroke of the T wave. Yeah, exactly right there. That also conducts with a prolonged PR, but it does conduct. And then you have, if you look at the very top of your T wave, you see how this T wave is taller than the one before. I think your P wave is sitting right there at the top, making your T wave taller. That one blocks, no QRS. And then you have, again, your next one easily visible in the baseline, conducting with a long PR. So that's, if we go back to the first beat in that little set that we looked at, you can see you've got PQRS, PQRS, P block, PQRS. So that's a 3-to-2.
Great, wonderful. Can share the next one, Dr. Kasturi?
Yes. This is when the child was sleeping early, like midnight.
And that's a great point too, when you have the slower rates or the increased block, what is the child doing at that time, or what time are we noticing these? Very different sleeping at night versus exercising and playing, and that's when you start this rate and rhythm. So any added concern, Beth or Tony, on this?
I do think there is conduction. And so even though you do see more than one blocked P wave in a row, like on the first line, I think after the third QRS, then there's 2 blocked P waves in a row, and what looks like a junctional escape, because that PR is probably too short to conduct. But I think not the next P wave, but the next P wave does conduct, and it is 2-to-1 for the rest of that page. So I think there, I guess technically if you have 2 blocked P waves, you do have short-term complete heart block, but I do think there is still conduction and Mobitz type 2 block.
I agree with that completely. And the kind of clue to that here is that long interval in the middle, the one with the heart rate of 41. That long interval is kind of what you expect your junctional escape is likely to be. And so if you have R to R intervals that are faster than that, then something's pulling them forward, right? So it's that same irregularity that we talked about as being the clue. I don't think we can prove on this strip whether that longest R to R interval is a junctional escape. On the bottom one, sorry, the top one is definitely a junctional escape, because as Tony said, the PR is too short to conduct. On the bottom strip, again with a heart rate of 41, it may just be that with 3 blocked P waves, you've had enough recovery, like in Wenckebach, right, that your next PR has shortened. So the differences can be quite subtle. So that bottom strip with a rate of 41 could well be conduction. The top strip with the very short PR, I agree, has to be junctional.
Wonderful. Dr. Kasturi, we can keep going.
This is the time where at 8:40 in the morning, whenever the child was active, he was actually conducting 1:1 completely. His even sinus rate also had increased. Previously, the sinus rate was only somewhere around 100, 120, but this has a very good sinus rate with 1:1 conduction. So the child had both, had a high sinus rate with 1:1 conduction at some point of time, and sort of a high degree AV block or a complete heart block at some point in the day. So summary is a 15-month-old asymptomatic child with transient AV nodal block, which was ranging from first degree to intermittent 2:1 to high degree AV block without any identifiable risk factors.
All right. So you want to tell us what you ended up doing?
We've currently put the child under follow-up only, sir, because he's completely asymptomatic and he's doesn't require anything right now. But we have asked them to follow us, every 3 monthly once. We sort of try to educate the parents what can happen, because this is the time when the child actually starts walking and starts running around. This is the time when they would the heart block might progress and when he might fall down and all. So we told the parents, we even told that the child might require a pacemaker because of the high degree and whatever we had seen for the 6 months. There is a definite progression in this, even though we hadn't done a Holter at that time. But still, I'm sure that there is a progression of this AV block. So we told the parents that the child might require a pacemaker. So currently, we have kept the child under follow.
Tony or Beth, any comments on some of the syndromes that have progressive heart block associated? I mean, should there be an other additional workup you would consider in this scenario, or just follow?
I think with structurally normal heart, there's not really many syndromes. I think with there are genetic conduction system diseases, and I think that's why you brought up doing genetic testing early on. It's usually not super helpful in terms of what you actually do or your management, but maybe we can have Beth comment as well.
Oh, I agree completely. In a structurally normal heart and a non-dysmorphic, developmentally normal child, I would not be pursuing additional diagnoses. That said, if an abnormal echo or a dysmorphic child or developmental abnormalities, then I think you do need to reopen that door and consider it.
I have seen an NKX 2.5 in somebody with a structurally normal heart. Not that it matters for this child, you're absolutely right. It does potentially matter for the parents because one of them may carry it, and then obviously the future offspring. Actually, interestingly, this child's dad had been told, white guy from Utah, had been told that his heart block was from Chagas disease. Pretty unlikely. And then when we found the NKX in the kid, the dad was also positive.
If the father had not also had heart block, would you have done that testing? Because I don't think I would have without the family history. Absolutely
not. Yeah, it was the dad going, I had Chagas disease from when I did my mission in Peru. And I'm like, really? You lived in a hut?
I think that's hey, this is Pete. Hey, everybody. Sorry to jump in here in the 9th inning. And I hopefully I'm somewhat on base and not talking about something totally different here. But I'm glad, Susan, you brought up the NKX issue, because I think that's probably one of the few genetic disorders that involves heart block where there is some prognostic implication, because in NKX, one is that you would expect this nodal disease to be progressive. So if you're seeing some conduction now, it wouldn't be surprising in a year or 2 years or 5 years that you devolve into complete heart block. And the other is we wrote about this a bit ago, and we're hoping to collaborate a bit with the PACES group to learn a little bit more about this. But there are other tachyarrhythmia substrates that these patients can get, AFib being one of them, and unfortunately VT and sudden death being the other, that require a pretty close eye on patients like this. I agree, though, in the absence of septal defects and a family history, I'm not so sure I would go looking for NKX variant here. But if you had any inkling of even syncope, if it was sort of a soft call, but getting EKGs on the parents is a very reasonable thing to do in this circumstance, just to know whether you should be exploring NKX any further.
Great. I think that's a great point that Pete, you just mentioned. In unusual rhythm problems, it's always wise to get ECGs on first-degree relatives. People can remain asymptomatic for long periods of time, especially with bradyarrhythmias.
Yeah, and some
mentioned Curran Sayer and Pearson is sort of the less common counterpart. Those mitochondrial disorders typically have other phenotype associated with them. So you have the the unilateral ptosis is a hallmark of that. And also muscle weakness. And in Pearson's kids, they get leukopenia and neutropenia and need blood transfusions or are kind of sick when they're born. So usually those kids don't fly under the radar. But having said all that, we see, I'm sure every EP on the call will agree with this. There's a kid like this every couple of months that has like some degree of a bit of nodal disease, but they're otherwise okay, that we kind of sit on. And a lot of them never progress. And I don't know what happens to them when they're 30, but certainly when they're 18 and younger, we don't see anything bad happen to them.
Yeah, no, great points, guys. We can all come up with anecdotal cases, and I had a case with Karan Sayers that initially completely normal EKG, but then came in with syncopal episodes, and we put a monitor on, and lo and behold, he was having these like really long pauses, and then he was fine in between. So when you do the EKG, it looked fine, and then unless you did a longer term monitoring, you wouldn't have picked that up. And pretty quickly, he progressed to where he had no underlying rhythm at all. Like he had complete AV block and no sinus. So basically, completely pacer dependent. So sometimes they're rare, these cases, but that's why I brought up the whole idea of genetic testing, how much and to what extent you pursue it.
Yeah, and AJ, the mitochondrial kids, and this is what you're alluding to, the progression can be very, very fast. So, once we see, even a bundle, that's a class 2A indication to put a device in. And we've seen kids with bundles that a week later, it's a new onset, and a week later, they're in complete heart block. So, and yeah, another circumstance where knowing what an underlying diagnosis would be helpful. But again, those patients usually don't fly under the radar.
And just for my knowledge, I know in the US and the Western world, genetic testing has now become very readily available. Dr. Kasturi, how about in India and some of the other countries? How easy is it to get genetic testing for these kind of diagnoses?
We have some medical laboratories which do the genetic testing, sir, but it happens only in some 3 or 4 cities in India. So if at all we have to get it done, we have to take the blood sample and send it them across. We can get it tested, but the reports, we usually get it in some one and a half months time.
Yeah, and is it pretty reasonable? Is it affordable for the families to be able to do this kind of testing?
That's a very big question. We try to persuade them. We try to say, see, this is very important to your child. You please try to get it done. We somehow sponsor it half and ask them to pay half. Sometimes we negotiate with the laboratories and get it done.
Very nice.
I would say under those conditions in a child like this, I would not be advocating for any testing. I think it's important to think about the implications, the likelihood in this child with a normal echo, no family history, absolutely non-dysmorphic, developmentally normal. The odds of finding anything that are useful are infinitesimally small, and I would not advocate for that for this family.
Great points, guys.
Question on the chat about Lyme disease. Anybody want to comment on Lyme disease?
Only to ask whether there's Lyme disease in India.
We don't have Lyme disease, madam. We have more of diphtheria.
Excellent.
But,
Glad you don't have Lyme disease.
But I think Lyme disease it can present as a high grade or complete AV block, and it does usually resolve with actual treatment of Lyme disease, which is an important thing. So those are ones, even if somebody comes in with, let's say, new complete AV block or even new symptomatic AV block, and I recall one case early in my career where it was Lyme disease, and you treat it appropriately with antibiotics while watching the patient in the hospital, and the AV conduction completely resolves. And so, that might be a case of, we don't want to have, be too, jump the gun too much on placing a pacemaker if there are reversible causes.
So, one of the mottos of this meeting is all teach, all learn. I've never seen diphtheria associated heart block. Is there anybody in the audience who has seen a case of diphtheria associated heart block? How do they present and how do you treat them? Can you just educate us a little bit, please?
Sir, I can answer it. diphtheria usually with the heart blocks, it comes in adolescent children. They will be recovering from respiratory symptoms, and suddenly they would still be in the hospital and everything. Suddenly the treating pediatrician will see that the heart rate had reduced. So then they'll be sent. They will even have bundle branch blocks, high grade AV blocks. We even had 2 children where we had to put temporary pacemakers, till that heart rate had come up. And we treat them with the antitoxins and everything, but the damage had already happened to the bundle, so it will take a little more time for it to be reversible. There was one case report where a diphtheric AV block had not come back to the sinus rhythm, where the child required a permanent pacemaker, but most of them will come back with the temporary pacemakers and symptomatic management. This actually happened quite a bit because there was some reduction in vaccination, especially in the adolescent age group, where they had to take a DPT booster according to the Indian immunization norms, where they just forget and say it's okay. Somehow the adolescent age group was badly hit there.
Great. I think, we're getting close to our hour, and we have a nice didactic summary coming up on heart block after this. So I thought maybe if we can, unless somebody has some dying comments that they really want to make, let's go to the didactic session.
Thank you, everybody. Thank you, Children's Heartbeat. So I'll stop sharing my screen now.
Excellent job.
So the didactic today is going to be by Dr. Jordan Ezekian, who's a fellow at Hospital for Sick Children. So welcome, Dr. Ezekian. Please go ahead and share your presentation. Thank you.
Thank you. Can everyone see my slides? Perfect. So we've covered actually a lot of what I was going to review today. So that's great. So hopefully this is a nice ending to the session here. So here's kind of what I plan to talk about. Types of AV block. We've sort of talked through this, but we'll just review those, go over some causes of AV block, how these children tend to present, and then review the pacing guidelines at the end. So just a quick review of anatomy. Again, I hope you can see my pointer. The AV node lives here within the triangle of Koch, which is bordered by the coronary sinus os, the tendon of Tadaro, and then the septal leaflet of the tricuspid valve. So the types of AV block, of course, you have first degree AV block, which is actually a little bit of a misnomer because the electricity does make it from atrium to ventricle, so it's more of a delay. So here's an example. You can see here that the P waves, maybe if you look in V2 here, that's a nice P wave. The PR interval is quite long in this example, but each beat is conducted. So P, QRS, in each P is followed by a QRS complex. And so this is usually normal, of no clinical significance, and is usually associated with increased vagal tone, particularly at night during sleep. If you read a lot of Holters, you'll see this a lot, particularly in like teenagers. When they go to sleep, they have decreased sympathetic input, so their parasympathetic tone is increased relatively, and so that vagal tone is more, and that just slows conduction through the AV node. You actually see this in about 8% of normal children. But if the PR interval is prolonged over 300 milliseconds, that's when you kind of start to think, okay, that's probably abnormal. This needs to be investigated. And especially if it doesn't shorten, if the PR interval doesn't shorten with increasing heart rates. Next is second degree AV block. So there's of course 2 categories, which we talked about before. So I've tried to highlight in the examples here for you. So you follow the PR interval. So Mobitz 1 or Wenckebach is a progressive PR prolongation. So starting on the shorter side here, lengthening with each progressive beat, and then at some point, the P wave just doesn't conduct. And then classically, the next PR interval is shorter than the preceding PR interval that did conduct. So that is also a normal finding. Again, we see this a lot on Holters, on teenagers while they're asleep maybe, and it's not necessarily a pathologic finding. And again, it's due to increased vagal tone. if you have no PR prolongation prior to the drop, so in this example, the PR interval is quite stable, and then you just have a beat that doesn't conduct, this is always pathologic. And then, it kind of varies how you're going to respond to that, but that is not a normal finding. Third degree AV block, or complete AV block, is a complete AV dissociation. And again, we had some good conversation about differentiating complete AV block versus high grade AV block. So if your RR intervals are very stable and there's really not any QRS complexes that are pulled in, and then the P waves are kind of just marching through, kind of not associated in any way, then that's complete heart block. And you'll get either a narrow junctional escape rhythm, like shown here, or a wide complex QRS, which is more of a ventricular escape, and is generally thought to be less stable. So I think in prior sessions, this has been covered pretty well, so I won't belabor this too much, but again, we alluded to some of this. There are different causes of heart block in children, and so these are the main ones. So congenital heart block, about 1 in 20,000 live births are affected by congenital heart block. This develops in fetal life, in the 18 to 30 week range, and is often seen on fetal echocardiogram, and is secondary to maternal. A lot of the cases are secondary to maternal autoimmune disease, and exposure to those maternal autoantibodies, which cross the placenta and then act on conduction tissue. So testing for those maternal autoantibodies can be helpful, anti-Ro, anti-LA. And then complete heart block develops in a small percentage of those affected pregnancies, and you can just see variable heart block in general. And so the outcome of that varies greatly. You might only have, you might just watch the patient, as we discussed, or they might actually need a pacemaker kind of following birth. Structural heart disease, it's a big category. So you can have things like AV canal, AV septal defects with inferior displacement of the compact AV node, and there are syndromes associated with AV septal defects. We talked about genetic predispositions as well, TBX5, Holt-Oram, where they also have limb abnormalities, and then NKX was discussed as well, that can cause heart block. And then congenitally corrected transposition of the great arteries is another one, where you have L looping of the ventricles causing anterior displacement of the AV node. And these patients actually have a 2% per year risk of heart block as they grow. And then by adulthood, about 40% will have complete heart block. And then we talked a lot about infections. Those are required ones and often reversible causes of complete heart block. So Lyme disease, Chagas, acute rheumatic fever, things like that. And then you can also get acquired heart block from surgery, for any cardiac surgery in the area of the AV node. And so those are reasons why potentially there might be interruption of the conduction system. And then there are some rare idiopathic causes or familial genetic causes as well. So how do they present? So the presentation really varies with age. If you have a baby with heart block, the presentation might be very different than if it's an active teenager that's going into heart block and they haven't had heart block their whole life. So you can either be very asymptomatic because you maybe just have always had heart block to some degree, or it only happens at particular times, like when you're asleep. Or it can present with syncope or even sudden cardiac death. And so those symptoms really depend on what is the junctional escape rate. Is that something that supports your activities and what you're trying to do? Is it high enough? Or do you not have a sufficient junctional escape rate? So on workup, we do ECG, Holter as discussed. You can also do an exercise study if the children are, old enough to participate in that, to determine if they can, in times of exercise, really generate enough of a rate to support their activities. And then always we want to investigate any reversible causes, because we would definitely want to identify that and treat it, and that might save the patient from needing a pacemaker. And then, acutely, if they're, if they do present with, syncope, they're very symptomatic, we might need to, might be in a kind of a code blue situation. And so you would definitely use your PALS cardiac arrest algorithm or symptomatic bradycardia algorithm, and then transcutaneous pacing acutely can be helpful, or even transvenous pacing. These are the guidelines that were alluded to in our discussion before. So first, it's important to talk about who needs pacing, because we want to make sure that we're pacing everyone who needs it. So I'll call your attention to the top two. When we talked about this, if there are symptoms associated with heart block, then that's really what guides most of our decisions. So advanced heart AV block with symptomatic bradycardia or ventricular dysfunction, low cardiac output, those are going to be class 1 indications for pacemaker implantation. And then sinus node dysfunction with symptoms and causing symptoms due to the inappropriate bradycardia for age. And then the remainder of this list, it's kind of like postoperative, which could be a talk in and of itself, heart block that persists, and then congenital complete AV block that either with a wide QRS escape rhythm or complex ventricular ectopy or ventricular dysfunction. That's an indication for placement of a pacemaker. And then the rate, this is the old guidelines, but the rate, a ventricular rate less than, in the 50s is thought to be not, sufficient. And if there's congenital heart disease present, then, the thinking is they need a higher ventricular rate. And then who do we not pace? So we want to make sure that we're not over pacing because placement of a pacemaker is not trivial in children, particularly if they're very small. So if the AV block is transient, particularly if it's in a post-op period and there's return of normal AV conduction in an otherwise asymptomatic patient, those patients don't require pacing. Focus again is really on symptoms. So if they're having some AV block, even type 2 second degree AV block and they're asymptomatic, you might choose to hold off on pacing and kind of follow them clinically. And then if they just have sinus bradycardia that's asymptomatic, that's not an indication for pacing either. So I just have a couple of wrap-up questions here. So the first question is, you have an asymptomatic 15-year-old girl with a normal exam who you do a 24-hour Holter and you find that she has the rhythm below while she's sleeping. The remainder of her Holter is normal. So what would be the next most appropriate step? Is it A, an EP study, B, an exercise treadmill test, C, cardiac MRI, D, reassure the patient, or E, pacemaker implantation? Okay, looks like a couple of votes for EP study and a few for exercise treadmill test, but most people want to reassure the patient, which is the if this is the only finding in the Holter, this is reassuring. So this is occurring when she's asleep. She's a normal teenager. We know that the vagal tone in teenagers, particularly during sleep, is increased, and so that can cause Wenke box. So you have again looking at the PR intervals, and are they progressively getting longer? And in this case, they are. So they start out pretty short. The next one is longer, and then this P wave doesn't conduct. And then the following conducted PR interval is shorter. So this is very classic for Wenke box. It's not anything we need to do about that. Here's the second question. So a 60-year-old boy presents with a rash on his leg with central clearing and overall just non-specific joint pain, and on ECG, an ECG is performed, which is shown here. And on history, the family had been on a camping trip last month. And so the question is true or false? The patient should be scheduled for an urgent permanent pacemaker implantation. Yeah, I think the poll is open now. Okay, looks like there's a lot of consensus here, which is good. So I would say the answer is false. This isn't an indication for permanent pacing, because at least not yet, because so in the ECG shown here, there is heart block. However, because you can see the QRS, the R to R interval is kind of marching along, no real change, and then you have P waves that are kind of dissociated. So this is complete AV block, but the history gives you a clue that perhaps there's an acquired or infectious etiology of the complete heart block that should be investigated first. So this sounds a lot like maybe he has Lyme disease. So probably in this situation, you would send Lyme titers, you would treat the Lyme with antibiotics, and then kind of follow the patient to see if he's going to recover. And a lot of times they do. So not an indication yet for a permanent pacemaker. Okay, so so in review, asymptomatic heart block, or just heart block in general, the etiology and presentation can vary quite a bit. So we kind of have to take it case by case basis and see if there's anything reversible. Not all heart block requires pacing. If there are reversible causes, or if you know, the patient's asymptomatic, it might be appropriate to just follow them clinically and see how things progress. And we, in general, we want to avoid permanent pacing in asymptomatic patients and with these reversible causes. Thank you.
Thank you, Jordan. Thank you. This was an excellent session. Anjan, do you want to finish up?
Oh, no. Yeah, I'm still here. Thanks, Balaji. I think this was just echo it. Excellent session. Thanks for everybody for participating. And I think I'll echo a couple of last minute comments that you had brought up. Please share this CHP with all your friends and colleagues, people who want to join. I think one thing Balaji's been trying really hard to do is to get fellows and people in training to come and be a part of this audience. So it's a great session. It's free of cost. It's, you know, I learn every time I come on. So I'm sure there's a lot to learn. So please pass it on. The more people, the more merrier, the more fun it is, the more it grows. And also, if you have any interesting cases that you feel, hey, this would be really good, I learned a lot, maybe others can learn from it as well, pass it on, send an email to Balaji, and you know, we can look it up and pass it on. So we love more participation, we love more people to be on it. So please spread the word. Anything else anybody want to comment? I know it's
yeah, so the next thing is I just need to mention about next month's program. So Friday, the 28th of October will be the next program, same time. I don't think the clocks have changed yet. I think this year the clocks change early in November, if I'm not wrong. So time will remain the same for people in Asia. So with that, I think we can close today's session. Thank you, everybody. Thanks to the experts. Thanks, Dr. Kasturi. Thanks, Dr. Ezekian, for a great presentation. Thanks to all the audience. Nice to see lots of comments in the chat. So keep coming. Thank you.
Thank you, sir. Thanks a lot.
Thanks so much, everyone. Great job.
Thank you.
Thank you.
Bye.